Good evening, everybody. I welcome all of you to monthly clinical lecture of SLCOG. And this time, and this is a very important event in academic calendar of SLCOG. So this is the another Zoom lecture, and this is named as Master Class of Hysteroscopy, an indispensable tool in treating intrauterine pathology. And this time we have invited Professor Nishendra Karunarathne to deliver this very important lecture, and this will be mostly useful for the trainees who are new to the hysteroscopy, and as well as the consultant also. Before we start, may I invite Professor Hemantha Dodampahala to introduce Professor Nishendra Karunarathne. It's over to you, Hemantha.
Yeah, thank you, Professor Lanarol. Good evening, everyone. On behalf of the SLCOG, the Masterclass training, and it's a great opportunity for me to introduce Professor Nishendra Karunarathne, my respected junior colleague who graduated from Colombo Medical School. He was 3 years junior to me in the faculty, and he was outstanding graduate who completed his MBBS in 1997. And then immediately following the final MBBS, his internship, he was successful in his MS Part 1 and subsequently Part 2 in 2002. He obtained his MRCOG in 2004 after completing 2 years of specialist registrar appointment in York Hospital in UK. And he has worked as a consultant in the Ministry of Health for about 10 years time, and he has served as a visiting obstetrician gynecologist after his board certification at Dehiyatta Kandiya, Badulla, Balapitiya, Kalutara, Colombo South teaching, and he was our resident obstetrician at Disoisa Hospital for a long time. He has many researches and publications and orations, and won several prizes at his presentation, including the prize for the best paper at Young Gynecologists Forum in Auckland, New Zealand. He has served the college for many years in many capacities. Currently, he is the Secretary of Social Activities. And in recognition of his talents and his qualifications and service to the public and service to the SLCOG, he has been offered the clinical professorship in November 2021. He is a clinical professor named by the SLCOG. Currently, he is working as the lead obstetrician at Lanka Hospitals Private Limited, and he is the IVF specialist, and he is in charge of the IVF center at Lanka Hospital. He has a lot of experience in minimal invasive surgery, hysteroscopy, laparoscopy, and major gynecological surgery. So without any hesitation, let me now call upon Dr. Nishendra Karunarathne to deliver the lecture today. Over to you, Nishendra. Thank you.
Thank you, Professor Hemantha. Thank you for your kind words. And good afternoon, good evening, all colleagues. So what we're going to discuss here today is about the hysteroscopy, and in this we name it as an indispensable tool in treating intrauterine pathology. Of course, I consider the hysteroscopy is the most important and the most needed instrument in your armory of the gynecologist, I would say. When you order equipment, or maybe you're going for a new unit, you always look for laparoscopy, colposcopies, and the equipment for the major surgeries, labor ward equipment, and the scans and all. But you don't think hysteroscopy as an essential tool. But I think after this lecture, we all would understand we can do wonders, or maybe a lot of things from the hysteroscopy, and we must have a hysteroscopy in our unit. And Yeah, I would more concentrate on practical hysteroscopy here. I think anyone else can, uh, yeah, can read about the hysteroscopy mechanisms and the theory knowledge of it. But I think we should discuss something which is important when you're performing the hysteroscopy. Preparation is very important. You must have a transvaginal sound scan before you do the hysteroscopy, and before you know the pathology, you should not put the hysteroscope into the uterus. Preferably the scan done by yourself. Then only you know where to put and what to be done during the surgery. And the patient notes are very important. Of course, you have to go through them before the surgery. You would understand whether the patient had undergone a previous hysteroscopy or maybe another surgery, which would actually help you to understand or take precautions when you're doing the difficult hysteroscopy. The instrument should be familiar to you. When you start doing the procedure, you must make sure the instruments are all working well. And theater settings, assistant nurse, irrigation system is very important. You should have somebody to apply the pressure. Otherwise, you can't look at everything while you're doing the surgery. But if someone who knows your system, your methods, then you must place them at the correct position before you start the proceedings. The resection and diathem settings, and must make sure the correct settings have been done. Otherwise, you will burn things, or you may not perform the surgery well. Anesthesia is of paramount importance. You should have a very good anesthetist who is capable of looking after patients, the vital signs, the fluid overload, the embolism are being named as kind of complications in hysteroscopic surgeries. But if you have good anesthetists, those things could be minimized. And the basics in hysteroscopy, before you start in, like at this theater, you must position the patient well on the lithotripsy position. And the visualization is very important. Without getting a good visualization, you should never start cutting with sectoscope or scissors or anything. The timing must do it on time. Like don't have much time while doing the hysteroscopy, because your fluid is always running in and out, and also should not hurry also. Then you will perforate the uterus and must select the correct instrument. And here, yes, the visualization in the sense, before you put the hysteroscope inside, you must make it focused, and the focusing should be done very clearly and in a meticulous way. I use the fibers of the thread, the cloth, the wrapping, like theater cloths, and then I try to see the fibers in the theater cloth. Then I know it's well focused. So then I put in here. You see internal loss, and this is a patient with a lot of multiple fibers. If you have a good focusing outside, then you don't have to put the hysteroscope in and then focus again. Sometimes you have to, but most of the time you can have a very clear picture. And then next is how you handle it. Once you put the hysteroscope, you don't have to rotate, or maybe you can have to put from side to side. But there's a way of doing it. And when you, once after you put the hysteroscope in, I think you can hear the sound also. Open up and you go in at the level of fundus. You turn the light source to your right. Then you will see the left opening of the left fallopian tube opening. You turn it back onto the previous position. Go to the fundus and turn the light source to the left. Then you will visualize opening of the right fallopian tube. Okay, you come back and have a look at the fundal area, mid cavity, and the internal os, cervical canal, Yeah, here you would see the mechanism, the manipulations which I did. So I put the hysteroscope in and hold from the light source and rotate it to the one side, then you will see the opposite side internal loss. Then rotate, then take it back and rotate to the other side, then you will see the opposite side internal loss, the fallopian tube opening. So this is, once you practice it, of course you can have a good view, panoramic view of the uterine cavity, and you can see everything inside properly. And also you must make sure that you go in and have a look at the fundus and the cervical, the fallopian openings, and must do not forget, while you are coming back, look at the fundal area, the mid cavity, the inlet, and the cervical area as well. Everyone know the it's a simple thing that most simplest thing is to removing the polyp from the hysteroscope. What I want to show you here, this is a part of the polyp which earlier I have seen, and it was a big polyp, and I used a polyp forceps and removed, and then I had a second look here. Then again, I still see a part of the polyp there in the fundus, and I use the curettage again, but still a little bit of the polyp tissues are there. The root of the polyp is still there. Then, of course, you leave this little bit and come out, and then see it another 2-3 months time, you might see the polyp grows back again. Especially if you see the polyp and you do D and C rather than going for hysteroscopy, you would miss that. Then you can use the scissors, this use of scissors, and using scissors, you can remove the polyp from the root itself. The scissor is a very important instrument in the hysteroscopy instrument set. It can use for removing the polyps, sometimes the small fibroids, the septa, the adhesions, and always when you're ordering hysteroscopy, get a scissor, then you will do these kind of small manipulations. And this slide, this patient came to me with postmenopausal bleeding. So there was in the scan, there was some endometrial polyp also. So I put the hysteroscope, and the cavity was kind of narrow and fibrosed, and you'd have seen the polyp there at the fundus. But when I pull it out, I saw this lesion at the cervical level, irregular lesion with increased vascularity. Then I took a biopsy, and then I got to know later the histology came as the cervical cancer. So always, even if your scan says it's a polyp, you go in and have a look at the polyp, and while you're pulling out, look at the sides as well. Otherwise, you would miss an important pathology. And this is another very interesting the video. This patient had undergone myomectomy about maybe some time ago, and then came with subfertility, and I found another fibroid inside. You would see it on the right side. And apart from that, once the hysteroscopy has been put in, you found part of the threads, the white krill thread, which was used to suture the I think myometrial bed in the previous open surgery. I think lesson what you have to learn here is like when you're suturing the myometrial bed, and make sure that you are not putting the sutures into the uterine cavity. Sometimes they might not dissolve, they might not get absorbed, and then will act as a foreign body. Here you see the scar tissue around the white krill thread, and which I had to remove using the resectoscope. And then the patient, the cavity got cleared, and then you remove the white krill thread, and then she was ready for the fertility treatment again. So we'll go through this. Yeah, quickly. Yeah, this is the scar tissue which I removed with the white krill, and still scar tissue. which had gone into the myometrium, and so they all could be removed with using resectoscope, and you see some bleeding coming once after you removing the scar tissue, and you can use coagulation, and then you can by using the coagulation you can stop the bleeding points. This is what I'm doing there. You see, rather than using the cutting mode, you use coagulation and you apply it, and then the bleeding points will get stopped. So the bleeding is a common thing during the hysteroscopic surgery. The most important, identify the bleeding point, and then if you get a lot of bleeding, that means that you had gone into the normal tissue. So if you are cutting a lesion, you're cutting the scar tissue and all, then usually scar tissues, fibroids, they are less vascular. But if all of a sudden you see the bleeding is heavy, and then you must make sure that you are in the correct position or correct plane. And then by using this coagulation mode, you can stop the coagulation, applying to the correct point. This is, we are removing the submucosal fibroid with the resectoscope. It's an easy thing. You identify the fibroid, and then with correct visualization, the proper visualization with the correct intrauterine pressure, you slowly can remove the fibroid using the resectoscope. And you start from the distal end, from the cervical canal, and then you, with the resection, you pull the fibroid a little toward you, then you know that you're taking the correct pieces, like do it in correct way. And so these are initially, if you see a submucosal fibroid by using hysteroscope, you can do this kind of a surgery, and you are less. You don't have to have a lot of training and experience in removing the submucosal fibroid. But most important thing, and have a good visualization. Always look and have a good view before you applying your cutting mode to the resectoscope. And we'll go through this slide a little fast. Yeah, this is right here. We are at the bottom, the root of the fibroid. You remove the last bit of the fibroid, which is at the myometrium level, and you cut it out. And you see now you have removed almost all the fibroid, and you must identify, should be able to identify the myometrial tissue which appear in pink. Then you know that you have removed the fibroid completely, and take a little time, and then make sure that you have taken the fibroid completely, and have a second look. When you, after removing the fibroid, there's another fibroid on the other side, you can see. Yeah, that is, you have another look. You see still a little bit of fibroid tissue is there, then you can remove it to complete the job. Yeah, you just pull it out, or if you can't take it out that way, you can push the resectoscope very gently, and then you can cut the last bit of the fibroid tissue from the uterine walls. Okay. Then you remove the other fibroid, which is much easier thing. It's all superficial, the small one. Then you complete the surgery. We will go to the next one. This is another fibroid, but this is not that easy. It's at the corneal end. you see, and you see the fibroid outside. 1/3 of the fibroid is protruded like in submucosal, but most of the fibroids in the myometrium, in the intramural, and you see its uterus is vascular also, and you see a lot of blood vessels around, but still with the patience and with correct application of the resectoscope, you can remove this and you can start and then identify the fibroid and have a good visualization. I usually just try to clear the tissues around the fibroids using the resectoscope with applying on it without the current once or twice. Then you get a good view of the margins of the fibroid. Then you start cutting, and you can't handle the instrument, or you can't do the movement fast here, because one thing, it's in the cornwall, and you should be very meticulous about the place that you are cutting, and also it's difficult. It's with angle only, you have to use the resectoscope, and also make sure that you're not in hurry. Otherwise, you will, if you cut it extra unnecessarily, you will end up in perforation, which is really you or the patient doesn't want to have. And then you, little by little, you can remove the pieces of the fibroid. Now it's becoming a bit difficult because you can't grab them from the resectoscope, but then you can remove, you can just apply a little pressure on the fibroid, and then you will get a bit of a tissue in between your the blade and the handles, and then you can cut them. Apply a little pressure and wait for a while, then you will get another piece. So once you do it, you know which part to be taken next, and you must concentrate, should concentrate thoroughly on this thing. And you still have a lot of fibroid parts in the myometrium. And then I really want to show the whole video to you, then you would understand the steps of removing more difficult fibroids. So we'll go through this completely. Yeah. And then still quite amount of fibroid tissues are there in the myometrium, in the uterus, uterine walls. Right. You should have a good irrigation system, and you must make sure that your patient's vitals are being looked after well by the anesthetist. When I have difficult surgery, especially say my anesthetist, now be a bit careful and about the fluid retention and the other possible complications, so they would know. All right, and just cut in the bottom, like last, the deepest, most tissues of the fibroid now. You see the pink tissues appearing from outside, which of course, like you see the destiny. So when you see the pink tissues, you get much relieved because then you know you have gone into the last bit of the fibroid, the margins of fibroid. Now you're cutting the from those pink edges, and then you identify the fibroid tissues and apply a little pressure, and then cut with the resectoscope. And these patients, they are coming for the subfertile treatment, and we can't cut too much myometrium also. That will lead to scarring. So must be very specific in removing the fibroids and the leaving healthy myometrium behind. So you should done carefully and with a lot of patience. You see now the bleeding points starting to appear. That means they will come into the myometrial tissue. There's still a little bit of fibroid is there. You can remove that. Yeah, there you see the pink tissue beneath the the fibroid tissues. And then this point yeah. It's not easy cutting that end, so then you can, yeah, this, okay. You can push and give a cutter, give a cut, and then you can pull it out using the resectoscope with different maneuvering. Sometimes you have to struggle a little bit to get the last few pieces of the fibroid, but still you might be very cautious not to damage the myometrium and going through and through and then perfect uterus. You can cut in two ways, either by pulling or pushing. Then you are okay. That's the last piece, I suppose. Yeah. You see a lot of pink tissue on the operation field. That means you have taken almost all the fibroid tissue out of the myometrium. Okay, I think it's all done. Yeah, a few wedges are still there. You see, the bleeding is obstructing your view. You can diatomize by using coagulation the bleeding point here. You can just leave them alone and come because the patient will bleed post-operatively. Identify them and then slowly apply the coagulation. And they will stop. Here. Yeah, we will done. Yeah, almost. And you can go to the next slide. I think you had a good look at it. Yeah. Then adhesiolysis is also another operation that you can use with hysteroscope. And this patient came to our subfertility clinic with uterine adhesions. This is the uterine cavity she had, and all covered with adhesion. Of course, you can identify any landmarks, any anatomical points in this cavity. It's all covered with, it's all filled with adhesions. Adhesiolysis also, you must have your ultrasound scan pictures with you, then you know and the direction, so the way that you could dissect to get a good cavity. And you first have a good look at the cavity, and then you start with the scissors and you cut with the scissors and through the scar tissue. Then once you cut, you would see the scar tissue opens up, and you see the gaps in between the scar tissues. If it's a normal myometrial tissue, you won't see the gaps, but once the scar tissues are being cut, there are a lot of spaces. So then you would understand, so these are still the scar tissue. So you can't find an anatomical point in that side. So start from the another side, and then always have good visualization, and then go in and have a cut again. Yeah, and then you see the white tissue. Comparatively, they don't have blood vessels. The scar tissues, the vascularity is less, and then you may open up. There you see the space, so then you understand this is still a scar tissue. So put the scissor in and open up. Then again, come back again and get the orientation. Make sure that you are not going to the lateral walls. Always with in between your cutting, you pull the hysteroscope back and see you're in the correct pathway. So yeah, the adhesions, sure these adhesions, not the myometrium, the normal myometrium. Go through them, okay. Yeah, still, then you know, once you start cutting adhesion on one side, then you obviously understand the other side is also having the similar type of adhesions in the uterine cavity. So there you make sure that you are going into the you have to look, you have to open up till the time we go to the fallopian tube levels, the fallopian tube opening levels, but it's a kind of a blind procedure with you guess the depth, and then you open up and see with caution, and then you know that you are going through the adhesion correctly. And, yes, always use the scissors, and you do little dissection with the scissors as well. Like in any surgery, you just cut and then open with scissor tip, and then you go to the next step. Have a look again, and you know how far you have gone in. You still have to go. Just make sure that your distance and the directions are correct. Otherwise, you will turn into maybe to a lateral wall or sides. Then you see this thick adhesion. I can cut and remove them to get a good space here. So then the patient will have a more space when the endometrium grows up. In the lower part, you see some pinkish endometrium, which actually grow along the spaces once the space is created. So you should not damage like normal endometrium or the remaining the healthy tissues. Yeah, you get some sort of space, but still not enough. Now this cavity is narrowed from the sides as well. So you cut up to the level with scissor, and then you can cut to the side walls as well. But it's difficult with scissors. You might not be able to get a good grip from the scissor. But the scissor is the safest, most instrument here to start surgery with. We will, I think, make it a bit here. Yeah, this again. Yeah, once been cleared from the scissors, then you can use the hook with cutting, the section hook, to clear the lateral walls, and there you can get the space on the lateral walls using diathermy hook to use yeah. I think I have had a problem with the machine here. It's yeah, now it's working. Okay. And identify the directions, and then you use the diathermy hook to get the space on the lateral sides as well. And you must make sure that you are going through the adhesions, not through the myometrium. Most of the time, you would see the pink tissues on the side walls. And in the upper part also, you can use the diathermy hook to get the space. There you see you can use the upward pushing to separate the adhesions very carefully and gently. There you see. Then you come into the level. This is the tubal opening and the area, the corneal area, where the blood got collected. And then this is the all blood came through that little opening, which is the area where the tube is opening. So then you can make more spacious. And then you know that you have gone to the level of the tubal openings now. And let's see, yeah, some more. I will fast forward this a bit. Now you get that as landmark, then you can make the other cuttings or like resection. Then you know that you are at the corneal level, so then you can expand your resection and then get more space to the cavity. And yeah, we'll fast forward this for a while. So again, you're using the scissors on the other side, and you can use scissors once after the the landmark is being identified. And here the side walls. Okay, now you've got quite a good cavity here. You have another look. You might not see the cornwall end on the left side, but you can use. I couldn't find the cornwall end on the left side, but you found it on the right side. But this is a fairly okay cavity for fertility to patient to go through the fertility treatment. You went into the lateral wall and you found the blood vessels here. So once you find the big blood vessels, you should not cut further. That means you are in the myometrium. Sometimes we have to use the roller ball to stop this bleeding, and you identify the bleeding points, and then you can apply coagulation. You have a large bleeding sites. Now the bleeding stops. These are all good myometrium. You see the pinkish color here. Right, but have to stop the bleeding because you see the bleeding here also. Before you stop the surgery, before you come out, you must make sure this all the heavily bleeding points should be stopped. Otherwise, patient bleed post-operatively, then you have to do another procedure. Maybe patient had to undergo hysterectomy, or then no point your whole effort is in vain. So when the bleeding comes, don't panic, and you ask your assistant to apply more pressure to your irrigation system. Then the uterus gets expanded, and then identify the bleeding point, and then make sure that you are coagulating or diathromycin all the bleeding points before you stop the surgery, before you complete the surgery. This is this is another surgery which I want to show. The septum, intrauterine septum, and the uterine metroplasty. This patient is also found in subfertility clinic, which has a thick septum, intrauterine septum, and a very narrow cavity. Now you would see with scarring. When I put the resectoscope, it was difficult to identify the septum initially, but because it's very narrow, you have very little space to do the manipulation. This is right corner. You come back, and this is the thick septum. It's a very thick, and on your left is the left corner, right? So then you have to resect this. Normally, we use hook, the diathermy hook, to resect the septa, but this is too thick. Even if you divide this with the diathermy hook, then again, still you won't be able to have a good space, a good uterine cavity. So I used the resectoscope instead of the hook, and then you go in and identify the septa, and then the idea of resecting the uterine septa is you go to the level of the opening of the fallopian tube. So they are far away, they're deep, but you must be very careful in doing this. This is the thick septa, and then you have a good look, good visualization, and start with one side, and then you can resect the septa. And you always should have the orientation of the instruments and the dimensions of the uterus in your mind. So Otherwise, you will damage the uterus. So you see the septa in white tissue, they are not bleeding. They're all thick septal tissue. And once you start from the other side, you go to the left side. One side, you go to the left side and then identify the septum and then slowly resect with a lot of care. You see the pieces of the septum obstructing you. You can pull a little out and then you can get rid of them. Then you still see the septum. Quite a lot of tissues on there in the septum. You can cut now. Now you have more space to manipulate. You can put your resectoscope to the cornal end. You get a little space to manipulate here now. More space. There you see that from careful from the point that you're starting and then go through the septa and then you can divide it these are all thick septal tissues. You cut it up to the cornal end, cornal level. Yeah, then you see, you use it from the other side and then yeah, you can see on your left side, right side, the opening of the fallopian tube, and you come close to that. So that's your end point. We'll go through and make it fast forward. Yeah, so then this is after separating septa. You get this is you get a good space and a few remnants are there. I'm just taking out with the hysteroscope. And in this patient, the cavity is also narrow. So then I can use the hook to expand the cavity, call it metroplasty, the lateral metroplasty. Then you get more space there. Okay, do it on the other side. Yeah, right. So then you will expand the cavity and you get a good space, and then patient be more successful in the fertility treatment. Right, few things. The cervical canal, this is something again I have to emphasize you and tell explain you that this is bipolar hook. There's a instrument called bipolar hook where we can use in different manipulations. Here, this patient had a cyst under the endometrial surface. It's bulging into the cavity, so I use bipolar hook to remove that, and it can cut with very cautious, with care. We cut a little, and with this safer than using the resectoscope. And then you can do some coagulations in small bleeders, and then can do the coagulations in bleed. Now you see the component of the cyst came out all of a sudden. Now it's you're in the cyst and you can diatomize and then come out. So the bipole hook is also useful in minor procedures where you want to do little diatomization and and in small lesions. Now you see the cyst is being opened and then edges were diatomized. So then I think it will not get filled back again. And yeah, the cervical canal, this is a patient came with postmenopausal bleeding. So I tried to put my sound and it went up to a certain level, but they didn't go from there. So then I stopped dilating with canal. Then I used a hysteroscope. Of course, the patient had the long cervical canal, which of course you would not identify if you do the DNC, where you can't put anything beyond this internal loss, because the cervix is patulous and dilated here, the internal loss. And then in normal, the conventional DNC, I don't think you might not able to might not be able to get the tissues in the uterine cavity because it is not accessible. But when you put the hysteroscope, you would understand the space that you had seen, you had felt was not the uterine cavity. The uterine cavity is well above. And if you have any difficulty or not sure about the dimension, sure about we are in the cavity while they are doing the DNC or any small procedure, use the hysteroscope without further dilating, then identify the dimensions and then do the further dilatation. And the scratching is another procedure we do with the hysteroscope. This for the subfertility patients. You stimulate endometrium using hysteroscopy and scratching. You do a few scratches in the endometrium using the scissor, which considered to stimulate the endometrium and have a good endometrial receptivity in the next cycle. So there's a simple procedure. I just want to show you for your interest to understand what is actually the scratching is. Okay, so thank you very much. So those are the procedures we commonly do. I just want you to understand, so like the way we do the procedures, and with some experience, then you will understand hysteroscopy is a very important and safe and indispensable tool in treating uterine pathology. And start with small procedures, the simple procedures. Then you get your instrument correct, and then you start with simple submucosal fibroids, the adhesions, the scissors, and then with practice you can go up to a level that more difficult adhesive lysis and the intramural fibroids dissection could be performed. I think, do we get any questions? No. So unfortunately, might not be able to answer any questions here. Is there questions?
Okay, in the absence of questions, I would like to thank Professor Nishendra Karunarathne. Are there any questions?
I think there's one question. What's the question? Do you have to open up this? Yeah. Yes. This is a fluid management and the diathermy setting. Diathermies are, most of the time diathermies are being all they preset. You open most of the diathermies nowadays. They say the gynecology is small loop, the large loop, and then for the hysteroscopy you use specific diathermy machine. And I'm not quite sure what's the frequency and all, which I didn't bother to have a look, but they all are being preset. The companies, they show you the gynecology, this is the gynecology setups, then you would understand this is the diathermy setup. But when in the diathermy setup also, you will get numbers 1, 2, 3, or 4, 5. The 5 is the highest energy level. So you start with small one, maybe 1 or 2 initially, then you would understand whether it's enough to cut or not enough to cut. Then if you think it's not enough, you can increase a little, but don't start with highest level. And also to make sure that your fluid is being warmed well, but not too warmed as well. So there are reported cases that the patient had experienced burnt injuries because you used to warm the warm water with high temperature, which flows through the uterine and into the vagina, and then it had burnt the vaginal tissue and the perineum. And the fluid management, the book says is if I use now, we always use in saline. I don't think we don't now the hypotonic and hypertonic solutions have been not used. Theoretically, you can do surgery and must make sure that you're looking at the fluid deficit, but it's measuring the fluid deficit is very difficult. And you put a tube to your bucket, and then you try to calculate, but it's not easy. For these, what you should understand is you must make sure that you're not taking too much time on surgeries, and should not hurry also, but make sure that you do it in time and take little less time to complete the surgery. The important thing is good visualization. If you don't visualize the lesion or the intrauterine cavity, don't do it, and then you will end up in disasters or the complications. The ideal, the theoretically, they say if your fluid depth is more than 2 liters or 2.5, you should stop the proceedings. But your anesthetist is the one who knows really well about it, and good experienced anesthetist would say the patient is having fluid overload or any signs of embolism. So must, with the experience, you would understand now, like how to do it in a safer. So the other one, any complication you have encountered? Yes, I have once perforated the uterus. That is because I had my hysteroscope, and then all of a sudden that was not there, used by another surgeon. Then I was given the Euro hysteroscope. So I went through and struggled and didn't have any good visual parts. So I started cutting, and I ended up went into the peritoneal cavity, which was the nightmare for me. When you with the hysteroscope, you go into the cavity. So then, luckily, Dr. Kollure, the surgeon, I'm telling you my real experience, he was there. And I told him, but I knew that if you use the hysteroscope, then you should have a look into it. Then he came to my help, and he put the laparoscope and then had a look. And he went through the bowels, and nothing has happened. So luckily, there were no thermal injuries. So we came out and then observed and then went. So they always must call your surgical colleagues. If you had a hysteroscope injury, and then you go through and have a look, and you yourself you can do, but you're especially working in a private sector. Now, in case if you miss a thing, then you could be challenged by someone saying that you don't have knowledge to look into the bowel injuries. Or you obviously your surgeon are the one who can identify the bowel, and they can handle the bowel well, and they know how to look into the bowel injuries. So that happened to me. And apart from that, I tell you, there were 2 patients who had burnt injuries on their perineum, and that appeared a few hours later. That means the hot water had flown through the cervical os, and then had touched the perineum for quite a while, and then they came out with burnt injuries. So then I had to explain them, but the burnt injuries, they don't heal well. They went on for a while, but luckily they managed to get them completely cured. That's what happened. Use the SIMA, get the anatomical. Have you used ultrasound scan, anatomical? Not very frequently, but in a patient, yeah, in few occasions I did, and to identify certain things, but especially when you're doing the adhesive lysis. But it's a very important tool. If you feel like using the correct ultrasound scan, you do it. There's no it would give you advantage, and it's, of course, you can freely use it. No, I haven't. I haven't used this. Okay, I think yeah. The last question was that mosulator thing that we used to remove the fibers. I haven't used, and even we didn't have it.
Okay, thank you very much, Professor Nishendra Karunarathne, and I would like to thank organizers and the team from CIDES, Mr. Rajit and the team for sponsoring and helping on these equipments. Thank you very much, our fellows and members, for attending the webinar, and the trainees as well. This concludes the first webinar on our masterclass series, and we would come back with another webinar next month. Thank you very much.